Ptosis, it is defined as abnormal drooping of the upper eyelid is called ptosis. Normally the upper eyelid covers about 1/6 of the cornea, that is about 2 mm. Therefore in ptosis it covers more than 2 mm. Now coming to the types and etiology, that is a clinic etiological types. First one is a congenital ptosis. The congenital ptosis etiology, it is associated with the congenital weakness or the maldevelopment of the levator palpebrae superioris, that is the LPS muscle. Is seen in the weakness of the LPS muscle is seen in congenital ptosis. This here is LPS muscle. Now the characteristic features of congenital ptosis include drooping of one or both upper eyelid often since birth of variable severity. There is drooping of upper eyelid. Then lid crease is diminished or absent. This is because the LPS muscle is inserted onto the skin here. So since LPS muscle there is maldevelopment, there is lid crease will be absent in most cases. Then in lid lag on down gaze, that is there will be lid lag on down gaze, that is the ptotic lid is higher than the normal. Here we can see on down gaze there is lid lag, that is the ptotic lid is higher than the normal. It is due to the tethering effect of abnormal LPS muscle. Now this is in contrast to acquired ptosis. In acquired ptosis, the ptotic lid is lower than the normal in down gaze also. Then LPS function can be poor, fair or good depending upon the degree of weakness, which we will discuss later. Now, next coming to associated features. Based on the presence or absence of other associated feature, congenital ptosis may occur in the following form, that is simple congenital ptosis, that is not associated with any other anomalies, or congenital ptosis can be associated with superior rectus muscle anomaly. In telecanthus, there is increase in the interorbital distance in telecanthus. Then there is epicanthus inversus. Epicanthus inversus is defined as there is a skin fold. Here there is a skin fold rising from the medial lower lid and it is associating to the upper eyelid, that is epicanthus inversus. Or the congenital ptosis can be associated with congenital synkinetic ptosis, that is Marcus gun jaw winging phenomenon. Marcus gun jaw winging ptosis. In this condition, there occurs retraction of the ptotic lid with jaw movement, that is with stimulation of the ipsilateral pterygoid muscle. Here with jaw movement we can see the retraction of the ptotic lid because of the aberrant regeneration to the pterygoid muscle and to the LPS muscle of fifth limb. Marcus gun jaw winging syndrome, it is the most common type of congenital synkinetic neurogenic ptosis. It about 50% of congenital, about 5% of congenital ptosis manifest this phenomena. This synkinesis is thought to be caused by aberrant connection between motor division of cranial nerve 5 and levator muscle. Signs, as I already discussed, include retraction of the ptotic lid in conjunction with stimulation of the ipsilateral pterygoid muscle by chewing, sucking, opening the mouth, or contralateral jaw movement. Now, jaw winging phenomena does not improve with age, although patient may learn to mask it. Ptosis, depending upon the cause, it can be neurogenic, myogenic, aponeurotic or mechanical. Now first coming to neurogenic ptosis, it is caused by innervational defects, that is either third nerve palsy or Horner syndrome, ophthalmoplegic migraine, multiple sclerosis, etc. Now in Horner syndrome occurs due to oculosympathetic paralysis. That is, it is characterized by classic triad of mild ptosis due to paralysis of the Muller's muscle here. This here is a Muller's muscle. Then there can be miosis due to paralysis of the dilator pupillae or reduced ipsilateral swelling, that is anhidrosis, because the vasomotor and satellar nerve fibers are also paralyzed. Other features of Horner syndrome include mild enophthalmos, loss of ciliospinal reflex. Here we can see enophthalmos, then loss of ciliospinal reflex. Then heterochromia. There is ipsilateral iris will be lighter in color, that is heterochromia. And the pupil will be slow to dilate because sympathetic system is paralyzed, and there occurs slight elevation of the lower eyelid also because inverse ptosis. Now coming to acquired myogenic ptosis. Next is acquired myogenic ptosis. It can be due to different causes because of the LPS muscle or of the myoneural junction. Like different causes like seen in patients with myasthenia gravis, dystrophia myotonica, ocular myopathy, oculopharyngeal muscular dystrophy, and following trauma to the LPS muscle or thyrotoxicosis, Lambert-Eaton myasthenia syndrome, etc. Now separate videos done in Horner syndrome. If you want, you can see it. Next, coming to one is aponeurotic ptosis. It is another cause of acquired ptosis. It developed due to defect of the levator aponeurosis in presence of normal functioning muscle. Here we can see the aponeurosis of the levator muscle. The muscle function is more normal. It includes, the causes include aponeurosis affected. The causes include senile, that is old age involutional ptosis, or post-operative, such as in rarely observed in cataract or retinal detachment surgery, or ptosis due to aponeurotic weakness associated with blepharochaliasis. That is a condition in which there is swelling of the eyelid, or trauma due to trauma or disinsertion of the aponeurosis. Next cause can be mechanical ptosis. Mechanical, as we know, it can be due to excess weight. From the word itself, it is known that due to excess weight on the upper eyelid, as in here we can see, as in patients with lid tumors, multiple chalazions, lid edema, etc. It may also occur due to cicatricial causes, then it is known as cicatricial ptosis, as seen in patients with ocular cicatricial pemphigoid or trachoma. Now, coming to clinical evaluation, these are the following scheme may be adopted for the workup of a ptosis patient. First one includes history. History should include age, family history, then history of trauma, surgery, and variability in the degree of ptosis. Now, examination, coming to examination, we should initially exclude pseudotosis. That is, on inspection, it's the stimulated ptosis we should see, like ipsilateral. It can be either due to ipsilateral conditions where the eye looks smaller, such as in microphthalmos or phthisis bulbi, inophthalmos, prosthesis, brotosis. Here we can see inophthalmos, brotosis, dermatochiliasis, hypertropia, or contralateral conditions like eyelid retraction. We can see eyelid retraction here, or high myopic cases of proptosis. Then also the other eye might look ptotic in these cases. Now observe the following points, like whether the ptosis is unilateral or bilateral. Causes of bilateral ptosis can include congenital ptosis, or myasthenia gravis, myotonic dystrophy, Cancer syndrome, Lambert-Eaton syndrome, and chronic progressive external ophthalmoplegia also. Now, function of orbicularis muscle should be seen to see the seventh nerve. Then eyelid crease should be seen to rule out the congenital causes. Jaw winging phenomenon is present or not should be checked for. Associated features of any extraocular muscles should also be tested to rule out other causes of extraocular muscle, to rule out cranial nerve palsy, etc. Bell's phenomenon, it is a upward rotation of the eyeball on forceful closure of the eye. This is referred to as Bell's phenomenon. Now, confirmation of presence of Bell phenomenon is important before undertaking any surgical procedure to avoid risk of postoperative exposure keratopathy. Next, coming to measurement of amount of degree of ptosis. In unilateral cases, in ptosis, if there is a patient is having unilateral ptosis, difference between the vertical height of the palpable fissure of the two sides indicate the degree of ptosis. In bilateral cases, it can be determined by measuring the amount of cornea covered by the upper lid and then subtracting 2 mm, as normal cornea covers 2 mm. Ptosis is graded depending upon the amount, as mild if it is 2 mm covering 2 mm, moderate 3 mm, and severe when the ptosis is more than 4 mm, that is severe. Mild, moderate, and severe. When the ptosis is more than 4 mm, then it is graded as severe ptosis. Margin. Next is margin reflex distance. It refers to the distance between the upper lid margin and the corneal light reflex of a pen torch held in front of the patient on which the patient is looking. The pen torch is held onto the glabella, and then we measure the margin reflex distance. This is a margin reflex distance, the distance between the eyelid and the corneal reflex. Normally, it is about 4 to 5 mm. Margin reflex distance. It is the distance between the center of the lid margin of the upper eyelid and the light reflex on the cornea in primary position would give MRD 1. If the margin is above the light reflex, the MRD 1 has a positive value. If the lid margin is above the corneal reflex, in severe cases, if this lid margin is below the corneal reflex in severe cases, then it has a negative value. MRD1 is the single most effective measurement in describing the amount of ptosis. Normally it is about 4 to 5 mm. Next coming to assessment of levator function. Now it is determined by the lid excursion caused by the LPS muscle. That is the Burki's method. Here the patient is asked to look down. And the thumb of one hand is placed firmly against the eyebrow of the patient to block the action of the frontalis muscle by the examiner. Then the patient is asked to look up. And the amount of excursion, upper lid excursion, is measured with the ruler held in the other hand by the examiner. Levator function is graded as normal if the excursion is 15 mm, good if it is 8 mm or more, fair if it is 5 to 7 mm, and poor if it is 4 mm or less. So here we measure Burki's method, that is lid excursion. We measure the excursion of the upper lid from extreme down gaze to extreme up gaze with the action of frontalis muscle blocked. Patient is positioned against a wall while the surgeon's hands press the forehead above the eyebrow. Ensure that there is no downward or upward push, and the patient is then asked to look in extreme down gaze and then extreme up gaze. And the readings are recorded in millimeters. Normal eyelid excursion is between 12 to 17 mm, somewhere between 12 to 17 mm. We can do investigations like special investigations if required, especially in acquired ptosis, like the tensilon test to rule out myasthenia. There will be improvement of ptosis with intravenous hydrophonium tensilon in myasthenia gravis patients. Then phenylephrine to rule out Horner syndrome. Horner syndrome we have discussed in a separate video. If you want, you can watch it. Then neurological investigation may be required to find out the cause in patients with neurogenic ptosis. Then photographic record of the patient should be maintained for comparison. Photographs should be taken in primary position as well as in up and downward cases. Next, coming to treatment of congenital ptosis, it is almost always congenital ptosis almost always needs surgical correction. In severe ptosis, surgery should be performed at the earliest to prevent stimulus deprivation and amblyopia. In mild to moderate cases where the visual axis is median, surgery can be delayed up to 3 to 4 years when accurate measurements are possible. Congenital ptosis can be treated by the following surgeries, that is tarsoconjunctivo-mullerectomy. First one, it is also known as the fascicular servette operation. It is performed in case of mild ptosis, that is 1.5 to 2 mm and good levator function. In it, the upper lid is everted. Here the upper lid is everted and the upper tarsal border along with its attached muller muscle and conjunctiva are resected. Here we can see the tarsal conjunctivo-mullerectomy. Here the upper conjunctiva, the muller muscle and the tarsal plate. Here conjunctiva, muller muscle and the tarsal plate. It is resected. Lid is everted and the tarsal border along with its attached muller muscle and the conjunctiva are resected. In case of fascicular servette procedure. Next, we can do a levator resection. Levator resection, it is a very commonly performed operation for moderate and severe ptosis. Fascicular servette is for mild ptosis. For moderate and severe, we do levator resection. It is contraindicated in patients having severe ptosis with poor levator function. Now, the amount of levator function required, most of the surgeons find it out by adjusting the lid margin in relation to the cornea during operation on the table in individual cases. However, rough estimate is in different grades of ptosis can be made. Moderate ptosis, depending upon the level of LPS function, the amount of LPS to be resected is as, like if there's a function is good function, then 16 to 17 mm, fair function, then 18 to 22 mm, poor function 23 to 24 mm, and its severe ptosis, levator function, fair levator function 23 to 24 mm. Maximum LPS resection is 23 to 24 mm. Here the techniques are levator resection. The techniques are levator muscle may be resected either by conjunctival or skin approach. This here is a levator muscle. Levator resection is the most commonly practiced surgery for ptosis correction. It may be performed through either the skin approach or the conjunctival route. This here is a levator muscle. Levator resection is the most commonly practiced surgery for ptosis correction. It may be performed through either the skin approach or the conjunctival route. Conjunctival resection of the levator muscle by conjunctival approach is known as Blaskowitz operation. Here the technique is comparatively easy but not suitable for large amount of resection. In it, the LPS muscle is exposed by an incision made through the conjunctiva. Here we double evert the eyelid using the Descemet's load retractor, and the LPS muscle is exposed by an incision which is made through the conjunctiva near the upper tarsal border. After the upper eyelid is doubly everted using a Descemet's load retraction, and the levator resection is done. Now the skin approach after everting. Now the skin approach of levator resection, it is known as the Everbush operation. It is a more frequently employed technique. It allows comparatively better exposure of the LPS muscle to a skin incision along the line of future lid crease. Next operation is brow suspension, that is a frontalis Sinks surgery. Here this is performed in patients having severe ptosis with no levator function. In this operation, lid is anchored to the frontalis muscle via a sling. It can be facial lata, that is a best material, or some non-absorbable material. So we can see the levator muscle is attached to the using a sling. Non-absorbable sutures like include examples of supramide suture, silicone rod can be used as a sling here. The sling. Now treatment of acquired ptosis. We should treat the underlying cause wherever possible. Conservative treatment should be carried out and surgery should be deferred for at least 6 months in neurogenic, that is in nerve palsies. Surgical procedures when required for acquired ptosis is essentially the same as described for the congenital. However, the amount of levator resection required is always less than congenital of the same degree. Further, in most cases, a simple facial servette procedure is adequate.